Good. Thank you for the kind introduction and the opportunity to present our work here today. I have nothing to disclose. I would like to start with a short poll. So please find the QR code shortly displayed. The question is, you're performing spinal lumbar endoscopy, a discectomy, and suddenly the view is deteriorating. And are you now, what are you going to do? Are you A, increasing the pump pressure or the gravity pressure? Are you B, occluding the irrigation backflow at the endoscope? Or C, both of the above? Or D, you proceed with the endoscopy because you're not sure about the consequences of these maneuvers? So I give you a short moment. Can you please show the results? Okay, so we have more or less a clear winner with the increase of the pump or gravity pressure. So we proceed with the presentation, thank you. So in spinal endoscopy, cerebral complications have been described during or after endoscopy, yet the underlying mechanisms remain unclear. And so our hypothesis was that these adverse events might be due to increased intracranial pressure, presumably induced by increased spinal pressures caused by fluid irrigation during endoscopy. And so we performed an interlaminar endoscopic discectomy in 3 human specimens with and without a durotomy, and while concurrently measuring the pressures. So the setup looked like this. First, we performed a sacral approach, and through this sacral approach, we introduced pressure sensors at the lumbar, thoracic, and cervical intradural level, and also at the lumbar epidural level. After that, we also introduced a sensor to measure the ICP in the lateral ventricle and intraparahumally. After that, we performed the endoscopic lumbar discectomy at the level at3-4 with 3 different systems, a gravity system and 2 different pump systems. Finally, we performed a durotomy of 5 millimeter at the lumbar level and measured all the pressures again. So the setup finally looked like this. What we found is that there was a linear correlation of the measured pressures on the y-axis to the applied pressures at the x-axis in all 3 systems. And interestingly was that when you occlude the backflow of the irrigation at the endoscope, the pressures were always higher. You can see that in the light blue columns. And that was the same in all 3 specimens. We also found that trend at the other levels, so intracranially, cervical, and thoracic intradurally, as well as lumbar epidurally. And here again, we found always on the right-hand sided columns that with the irrigation backflow occlusion, the pressures were higher again. If we compare now the intradural with the epidural pressures, as long as the dura is closed, we could find obviously that the pressures at the epidural level were higher than the intradural. And what's also interesting, if you compare to the value of 25 millimeter mercury, which has been found in a clinical study to be the epidural pressure during full endoscopic discectomy, you can see that without occlusion, the values were always below that level, and with occlusion, it was exceeding it in all 3 systems and specimen. Really interesting now is that when you perform a durotomy and you look at the intracranial pressures at the absolute values, you can see that they were already close to the physiological level, maximal level of 15 millimeter mercury. But if you perform occlusion, they were largely exceeding this, and it was reaching up to 90 millimeter mercury. So, of course, inherent to the experimental fashion of the study, we couldn't account for physiological features like cerebral autoregulation or spinal fluid viscosity, and also the values differed individually, so you should not transfer those absolute exact values to the clinical situation. But to conclude, we could find a linear correlation during the endoscopy of the intra and epidural, as well as the intracranial pressures to the applied pressures. However, the pressures on the monitor of the pumps were not the measured pressures at the spinal level. The effect was always more pronounced if we occlude the irrigation backflow, so you should be careful with that. And the epidural pressure was not the same as the intradural pressure if the dura is closed. And in presence of a dural lesion, higher pump pressures and occlusion may lead to deleterious intracranial pressures. So coming back to the poll from the beginning, you should also be careful with very high pump pressures. And as my boss, Professor Farshad, always says, open dura, open backflows. Thank you for the attention.
Thank you, Dr. Schader, for a great presentation and a great study on an important topic, because that has been a concern for quite some time with endoscopy. So what kind of, I don't see any questions yet, do you think we do the discussion after? I think it's easier to walk on. So what's your conclusion out of that? So, because quite often you may not see the dural lesion, so the consequence, particularly in endoscopic surgery, so this may be a challenge, because saying you have to watch the backflow, if the dura is open, you may not notice it. So exactly. What's your consequence?
Well, it's just also to understand the underlying mechanisms, that you should be aware of it, and you should be careful with the occlusion. You could even rather increase the pressures a little bit. That's, I would say, less detrimental than really occluding the backflow. Because if you go back to physical laws, like the Bernoulli principle, like a liquid which is in a state that doesn't move, the pressure is higher than when it flows. So if you occlude the backflow, obviously in all the systems, either if you use gravity or pump pressures, the pressures will rise, so you should be really careful with it. But of course, with the irrigation liquid, you don't see maybe the liquor exiting the dura.